You're listening to the Physio Matters Podcast in association with Choose Health, and this is session 2. Thanks for tuning in to session 2 of the Physio Matters podcast. We're 4 weeks post-launch of session 1, and the response to the recording has been wholly positive. Well, but for some criticism of my dulcet northern accent, and I soon got over that. Session 1 made it to 1,000 downloads at around 3 weeks and peaked at 3rd in the iTunes medical podcast charts. So a massive thank you to those who've helped spread the word, particularly those who've tolerated me on Twitter. You want to find podcast debate and news at TPM Podcast, and find me, Jack Chew, at choose_health. Today's episode adds the second part to my interview with Dr. Lee Herrington discussing Patellofemoral Pain Syndrome. Although I doubt we'll lose you too much if you haven't, have a listen to part 1 if you haven't already. So let's get back to it. Let's try and put all this into a little bit more context and say, really broad case study of an amateur athlete presents with a chronic anterior knee pain that they could have abused to a various degree. What assessment options do you use?
I think the first thing you got to do is get a good subjective, and everybody says that. But there are certain things which you need to know from the athlete. First of all, you need to know how much do they do to bring on pain. And then you need to know how long does it take before they can do the same again. So let's go with the scenario and say this is an amateur runner who runs 3 miles and gets discomfort, which sort of he could keep running, but he doesn't really want to. So it's not painful enough to stop them running, but it's uncomfortable. And he can't run the next day. His legs stiff and sore the next morning. So we've got quite an irritable joint. We've probably got those OA changes going on. And so we know what his critical loading baseline is. That's our starting point, because through one aspect, we don't want this individual to rest, because rest will detrain those tissues. It will make them less resilient to load. So we want him to then keep running. That would be the first thing. The first thing I'd say to him is, look, I'm not going to stop you running unless I absolutely perceive it's deleterious to you. So it might be with our guy of 3 miles, we might say, okay, you can do 2 every third day to start with.
Right.
And you build from that base where we know you can cope.
So the relative rest principle still fundamental.
Totally. So that would be the first thing to get out, the subjective. And then we're around all the pain descriptors to try and come up with our differential diagnosis. So do we think we've got a retinacular, a synovial, a fat pad where we've got a highly innervated structure? So is their pain sharp? Is it specific? Or is it dull and diffuse? Is it something in the leg? Is it something superficial? The more superficial and specific, the more we think, you know what, we can take this, we can give him great pain relief. You know, if he offloads for a relatively short biological period of time, 1 week, and doesn't get his pain for a week, that tissue is going to be well on its way to healing, for want of a better word. Or if he's saying it's a deep ache within the joint, I get very stiff, we're thinking, okay, this is a degenerate, bone-related, arthritic-related stress. So we're already trying to counsel this patient. This is going to take a while to get a really good result. I can do the hocus-pocus magic on you. I can make you feel better. But if you want a long-term fix, we're going to need to build you up slowly, because the biology is wrong within your bone, within your joint. So we've done the subjective. We've come up with that. We've looked for the very overt red flags, obviously. And one of the ones we very much look at here, and from experiences, we look at lumbar spine, sacroiliac, hip pathology, even sort of quite covert pathology in those areas where they get a back. And we've done a couple of interesting things which haven't been published because they're quite hard to get out there. But we've done research where we've mobilized a hypomobile L3 segment and a hypomobile L3 segment. If you mobilize a hypomobile segment, you significantly increase their quads activation. If you mobilize a hypermobile segment, you can decrease their quads significantly. So we've got this whole kinetic chain thing as well we want to be aware of within the individual, both subjectively, have they had overt symptoms, which would definitely make you want to deal with them, and covertly, where we might think, in the back of my head, if my number one approach isn't working, perhaps I need to then look a little further afield to get some stimulus into the kinetic chain to get it going. So subjectively, we'd go there, I guess. And then objectively, we pretty much always start with a patient stood up, because that's how they get injured. So it's the usual thing of, we very much don't get them on the bed until we've exhausted the standing stuff, unless they're very irritable. So they would stand, we would observe limb alignment, and then we would look at Q angle, bilateral stance into unilateral stance for the changes, and then get them to single leg weight bear, single leg squat, and again look at the way they do that, and we'll come back to that in a mo. And then we would get them, if asymptomatic, we may get them to hop onto the leg over a short distance, look at their landing strategy, or step onto the leg and look at a more dynamic loading strategy. So we've got a good impression, because there's quite good evidence now from people like Chris Watmore over in New Zealand that how people single leg squat very much reflects how they run. So if they've got an awful movement pattern to their single leg squat, we pretty much don't need to get them to run.
Okay.
It's going to go that way.
Yeah, so you've got a strong correlation that actually buys you time, doesn't it, in assessment?
Yeah.
Okay.
Whereas if they single leg squat well, then at that point we might even go down the route of getting them to run, because we really want to guide our secondary testing, if you like. Our primary testing would be on their feet, how do they move, and we would look at that, and then what are their symptoms, and then probably some of my colleagues would dispute this way of going. Then what we'll try and do is try and influence the symptoms. So let's say our runner here is in a little bit of discomfort after 10 single leg squats, and he's got a poor movement pattern, a typical dropping into knee valgus. So we'd go, okay, the first thing to try is then get him to improve that pattern. So we might facilitate and say, look, you're single leg squatting badly, try doing this. Look in the mirror, look at the video, try and improve your alignment. What happens to your symptoms? Now, if that changes straight away, we've got instant buy-in from the patient. Right, so work on X. If facilitation doesn't work and trying to change their movement pattern and he's still symptomatic, then what we might do is go, okay, why'd you get knee valgus? And we can sort of look at that in terms of proximal and distal factors in terms of why they get knee valgus, and we're very keen as physios to look at the gluteal muscles, and again I perfectly buy into that idea of always looking at people's bums, and though professionally we probably need to watch it a little bit, but so we'd look at gluteal muscle strength in terms of how that is going, and again what we look at there is we sort of think about what happened when they were doing the squat. So if they do a Trendelenburg, their pelvis drops, their weight shifts medial or laterally a lot in the frontal plane, you probably need to consider gluteus medius, or you probably need to consider their sort of sideline hip abduction strength and their side plank, for one of a better, decent lateral chain stability test. And if they're, collapsing into valgus because of hip adduction rotation, then you probably want to look at their clam strength, around the hip.
And so you're having to, in all of these fields, particularly when it comes to your functional single leg squat and standing tests, you've got to back your findings by the sound of things and have some conviction with what you've seen and what you're then going to treat. Where do you feel, it's going to be very specific to the person, but where do you feel you direct things more commonly? Is it proximal? Is it distal?
If I was going to say the things I would probably go to most would be generic eccentric quad strength. So actually they can't flex. So rather than flexing at the knee, they drop the knee in and they try and use their ITB to give them some stability or strength. So as you can imagine, as your hip goes into adduction, you wind up your ITB. So that gives you some intrinsic stability. It decelerates the load to a degree. And we've all seen patients eccentrically and going back up who let their knees drop in before they then move upwards, so in concentric phase as well, to try and preload. So look at quads pretty much, especially eccentric. And again, in the clinic, it's really simple. Can they lower themselves to a chair on one leg? Can they do a single leg squat eccentrically?
If that's particularly uncomfortable, do you feel you see enough on a double leg if something's quite irritable? Or
if something's quite irritable, then you're almost going, well, they're not ready for starting point. They're not ready for that. I'm going to need to work into that. My second probably go-to thing would either be a frontal plane strength thing, so a sideline abduction, sideline plank, or a clam type activity. Mm-hmm. But again, here you very much look for work capacity and strength. So we're looking at 25 plus repetitions as being an optimal test. The fact that they are, we have lots of toys here, like we have handheld dynamometers and ice kinetic dynamometers. We're looking at they can push, 40, 50, 60% of their body weight for repetition, because that's the sort of load they're going to have to counter when they're moving. So hip strength, if we call it that, whether that's through bridging, clam, sideline abduction, but progressed with work capacity would be another go-to. And then probably my other go-to thing would be ankle dorsiflexion. And again, a restriction in ankle dorsiflexion is very, very strongly linked to going into knee valgus in single leg squats, single leg lowers, and single leg lands. But it's not only looking at their ability to dorsiflex, it's the quality of that dorsiflexion, because if they do their dorsiflexion with pronation, they're already taking their knee in. So it's dorsiflexion at the talocrural joint, not just any old way of getting the knee to the wall sort of scenario. And then the final thing with that is probably in a dorsiflex position, how does their first metatarsophalangeal joint move? So you work down the chain. I suppose those are generally, if you look at those, you're probably going to hit up on 90% plus of the typical things which affect single leg squat, along with just them not knowing what they're doing wrong. So that sort of, don't forget to educate them first and see what happens, because that's the simplest fix.
Okay, of course, and they might end up telling you something that you would have missed. Yeah. And if I would just bring it back a little bit and say, the objective measures that you were saying that you can sort of gather with the gadgets and gizmos that you've got here at the university, do you use them because you have them, or do you use them because you consider them invaluable tools now?
I think the more objective data, certainly in my other job within the English Institute, the more numbers we can take to the coach, the better. So if we can say, look, jumping off a box equates to 2 times your body weight going through the limb, and they currently can leg press 0.5 of their body weight, that's why they collapse in a heap. We don't want them jumping and landing until they can get 2 times their body weight. So the numbers help. We don't want them cutting and changing direction until they've got a certain amount of gluteal strength, because we know gravity will force that knee in unless they've got an equal and opposite. We know they need so much knee to wall, symmetrical plus sort of over the toes before they can run without, having sufficient dorsiflexion. So we've got some numeric imperatives we have as a absolute minimum criteria. And that's quite important for us with coaches. They buy into numbers. They're very good with numbers. They're used to dealing with numbers. So if we say, look, their limb symmetry index strength is 60%, they go, 40% down, that's not good, is it? Okay, so they buy into that better. Yeah, so we use numbers because it gives us a lot more understanding. So it's not just there to justify your worth to the coaches, it's also there to direct rehab to some degree. Yeah, I mean, the real reason is because it then shows where we're going, whether what we do is bringing about an improvement. And again, we get a lot of, are you feeling better yet? And there's a lot of, come back in the treatment room because they like you, they feel better, or they don't want to tell you they're not feeling any better. And even at a sort of, everyday clinic level, the use of functional questionnaires and things like this, which you can get off the internet now. So for the anterior knee pain score, or the COOS questionnaire, where you can get the patient to score their activities of daily living, and you can show that, look, you've improved by 5 points or 10 points in a week. So you've had a 10% or 5% improvement. It's a physical being the patient can hook into. And, quite often the patient will get the same pain regardless of their level of function. We've all had patients who, they can't walk when you first see them, and then they're running 10 miles, but they're still moaning at you that it still hurts. And they're looking at you like you're rubbish.
So, starting to get them to recognise the progress they've made.
Actually, you've got the same pain, but you're putting far more stress through the system. So it's using that loading metric. And
just as I thought it would, we used such a broad case study that we ended up describing a whole array of treatments array of assessment options and then into treatment. But from what I'm gathering is, when it comes to anterior knee pain, a lot of people would think quite anatomically as well as biomechanically. There's a lot of underlying physiology understanding that you feel influences the direction that you take things.
Yeah, and we've got to understand how muscle strengthens and how long that takes. So if we think they're weak, they're 40% down, there's a X number of weeks to regain that strength. Even if we think that's a predominantly neurogenic issue, it's a skill learning issue, an ability to lift weight or re-engage those muscles, it still takes a period of time. So the more numbers we have, the more we can impart across the whole sort of piece in terms of sort of what we're doing with the individual. And in terms of to sort of go back to the measuring, as part of that loading biology, we also do knee osteoarthritis research here within the knee research group. And one of the things we think is quite powerful now is we try and get our patients, as one of our outcome measures, to wear a pedometer, and we get them to measure steps. So if they're doing more steps, they're improving.
Of course.
And it's really to empower the practitioner to show improvement. And in these days of purchasers and providers, and we think evidence-based medicine is all about high-flung science we do in university research labs, but actually we do this fairly standard knee class, but all the people in the knee class, their range of movement improved, their functional questionnaire improved, and their number of steps they did per day improved significantly. There's your evidence-based medicine.
So it doesn't always have to be glossy and fancy and sexy. It can be the basics.
I'd probably say if you come back to my research profile in years, I'll probably say some of the best things we'll do is simplify high science. So we're currently looking at qualitative scoring systems for single leg squat, single leg landing, which are validated against all the fancy high-tech kit. So what you have is something you can do in the clinic in real time, but have a very strong score which means something. Rather than, they're dropping into valgus, which you observe, we give you a scoring sheet, which again should be out within the next few months in terms of research. And then that gives the clinician, you were at 10, which is really rubbish, and look, you've got to 4 now, you're really coming on. So that's also empowering for the patient, because they see they're achieving a goal and they see they're improving. So psychologically, there's a benefit. Functionally, there's a benefit because within the questionnaire, for example, there's strategies the patient adapts, so it starts to focus possibly your rehabilitation. So at the end of all this research life cycle, if we get regarded as someone who took some high science and turned it into user-friendly stuff for the clinician, that'd be good.
You'd be happy to bow out at that one, yeah? Okay.
There's a lot of high science being done, and a lot of people, poo-poo the simple stuff, but at the end of the day, clinicians need stuff they can use in the clinic.
Of course, yeah.
Which is useful.
And something that we probably missed a little bit was, you mentioned ankle dorsiflexion, and that's really interesting that's a go-to thing. But also, in terms of podiatric changes or looking at foot posture and footfall and very specifics when it comes to gait analysis and force plate analysis, do you buy a lot of that when it comes to anterior knee pain?
Globally, we'll put people through full kinematic and kinetic analysis, and we'll look at their moments and we'll do all the clever mathematics. Definitely with an ACL profile population and a rehab population. But yes, the moments are important. For sure, you need that. You need to look at the forces, and the forces are probably incredibly significant with these individuals. But equally, we're probably going, well, what's changing? And orthotics is a really interesting thing. Orthotics for sure are probably like tape. What we know is if we give most patellofemoral patients an orthotic, it changes their pain. And Bill Vencino and Natalie Collins down in Australia done a couple of great studies to sort of show that. Give somebody an off-the-shelf orthotic and the pain goes away.
Tough to wean from though, isn't it, that?
The problem they've shown with their research is at 12 months they've got their pain back again, whether they keep wearing them or they don't. And so, again, like the tape, it's great and it gives you a window of opportunity. And again, if we simplistically look at the dorsiflexion issue, if we have somebody who achieves their dorsiflexion by pronating, if we stop them from pronating, then they can't dorsiflex anymore. So the obvious mechanical thing I would do then is probably externally rotate my hip and take my knee in, which at first works as a strategy because I'm doing a totally different load through my chain. But pretty quickly we can all see if we all start to walk in an external rotation and drop our knees in to achieve dorsiflexion, we're going to get pain down. So you can see how subtly the research shows they've still got anterior knee pain, but they've probably got anterior knee pain for a slightly different reason.
Yeah, so you end up chasing symptoms around a little bit.
You just change something and change something.
Okay, I mean, that brings in a little bit, and it was mentioned about how sometimes we're looking for answers that are broader than one structure, and that's quite clear when it comes to such a complex joint, we say. But you mentioned ITB, and that's something that is often, I don't know, blamed or considered to be the main thing that's affecting the patella and patella position, the way it tracks. Where do we sit with the research currently on that correlation?
ITB is quite, I guess it's amusing, and you can have a do and da moment over the ITB. If someone goes into valgus, they can't have a short ITB.
They wouldn't get there?
Because you can't get there. So industrial standard for, say, an Ober's test is probably a neutral hip adduction position or going in 5-10 degrees. That's from our paper from ages ago. So if someone has knock knees on a single leg squat or has that, they can't have a short ITB because unless their pelvis also goes up on the contralateral side, so they maintain 90 degrees between their pelvis and their femur, you can't have a short ITB because by definition you're going into adduction. So that would be the first point. Okay. That's probably why it doesn't work, because they don't have that as an issue. The second thing is we're probably looking at something we can't overly influence in terms of its femoral aspect, because it attaches down onto the femur through the full length. So what are we really influencing? That is not to say if we don't improve tissue stiffness and viability, we don't influence sort of the quad, which goes obviously into that fascial area, and we're not influencing things. So I'm not saying rolling the ITB and stuff like that before people write in and sort of complain has an effect, but it probably isn't a lengthening effect. It's probably a biological environmental effect, which is possibly decreasing the stiffness in the tissue and allowing you to elongate even more, so decelerating the load. But the other thing with the ITB is probably what happens down at the knee, which is probably where it's most interesting. We've done a very simple piece of work where we looked at essentially degree of patella tilt with an ultrasound scan. So we looked at how much the lateral border compressed onto the femur. And what we found was as you take the leg into adduction, guess what? Your distance between your patella and your femur decreases. When you go out into abduction, your distance between your femur and your patella increases. So what that shows is essentially the ITB at the knee, your deep lateral retinacular, is influenced by your ITB going down your leg, which sort of goes to say if somebody's going into adduction, they're going to tilt their patella more, which is why it's linked to patellofemoral pain. But the solution to that probably isn't getting them to go more and more into adduction, i.e. stretch the ITB. The solution probably is to get them better at holding the limb out to stop that adduction collapse and the greater tilting of the patella. And then you get probably the cadaveric work, which has shown when you load the ITB, essentially that tilts your patella, but also externally rotates your femur. Externally rotates your tibia. Which again, then we have the paradigm around pronation, which is pronation is supposed to be coupled with internal tibial rotation. So that should decrease your Q angle. So that should decrease the stress on the patellofemoral pain. It doesn't. And is that because actually you don't get a concurrent internal rotation of the tibia? And again, we've talked about proximal and distal. One of the local things to check with our patellofemoral patients is how much does their tibia internally rotate? So does their tibia internally rotate in a neutral position and in a hip adducted position? Or otherwise, we're potentially going to have to excessively pronate or drop our leg in to compensate for our lack of tibial rotation.
And do you want to test that functionally, or do you want to test that in prone on the bed?
It's prone passive, really. You know, in terms of, we've currently got a PhD student who's looking at that as a paradigm with all the clever sort of 3D kinematic kit, and even with bone pins and things like this. So we'll have a research answer to that question. But I just want them to prove their supervisor right, which is in some people it doesn't internally rotate when they pronate. And that's why people get problem. And again, then you get in your paradigm, stop them pronating. You really are going to affect further up the chain. So tibial rotation probably is the important element of what the ITB does.
Does that often get missed, do you feel? So in practice, I feel it does.
Again, I think that's probably one of the things which get missed. We worry about the ITB and we do release for that, but we don't do a lot of tibial rotation. And again, that's probably where some of the improvements we see with doing things on the ITB. So we take a male who is a little bit varus, so their knees are pointing out, so they are tight in their ITB on a classic Ober's test, then actually they're definitely, if they come to even a neutral knee position, going to be putting that lower sort of tibial patelloretinacular load through the patella. They're not going into the classic valgus, but actually that's why they're probably still stressing the situation. So it's sort of like classic valgus is one of the big things, but also then there's what else is happening around the system.
So with the ITB, if I make some sort of broad conclusions on a combination of a few of your research work, which I know we're going back a little bit, but if we were to say that there's only the jury's out on whether patellar position is a real key influencer in pain, and then we're finding that there's only a slight relationship between patellar position and the ITB length, do we need to stop caring as much about what the ITB is doing?
I think we need to clinically reason what the ITB is doing. So if we're seeing somebody going into valgus, one of our treatment priorities shouldn't be lengthening the ITB, it's probably stiffening the ITB, if you like, stopping them going into valgus. And the way to do that is tighten it up at the proximal end, which is your gluteal muscles. If they are standing in, 90 degrees pelvis to femur, then we might benefit from some relaxation, for want of a better word, of our ITB. So the ITB is less stiff, so it does elongate a little bit under load. There's a little elasticity in there, which might put less stress lower down out the knee. And I'd probably sort of, to a degree, I think, dispute we're ignoring the patella. We're getting obsessed with distal and proximal. And it's very hard on a podcast to sort of visually, if you see the patella sitting in the groove like the classical picture, and you tilt that patella to 15, 20 degrees, then you've got a point of contact. Now that point of contact stays like that, regardless of where you rotate the tibia or the femur, you're still going to have a patella which is not fully engaged in the trochlea. Mm-hmm. So we can do what we like, rotating the femur or the tibia, but we're not still going to have a localized stress. So I think we ignore the local patella position at our peril, especially if they have got a very tilted patella or a very rotated tibia, because that's going to change where it lies in terms of unit area stress within the groove. So I think we've got to think proximal and distal for sure, and we've got to clinically reason which we do from how they single leg squat, how they move, and make our decision off that. But equally, if in doubt, we probably still need to look at that local patella position, local tibial position, and see how that's moving. Because that's probably, again, we've done a lot of gluteal training, and they get glutes to die for, but they still have patellofemoral pain.
So we've got to make sure we come back.
Got to make sure we come back and make sure we've got local position going as well.
If we think about that we've identified these rehab goals and we've started to make progress. Progressing that rehab and getting someone back to where they need to be, that's sometimes difficult to bridge that gap from being able to tolerate our tests in the clinic and getting them back to sporting function or even basic ADLs. Do you feel like you've got any top tips in how to bridge that gap?
I guess the first one is that critical loading threshold. We said right at the beginning of the subjective of the case study, what can they do without pain? And we must keep them at that level. But we've got to have a degree of honesty from the patient there, you know. It's, well, the little old lady can manage, if we take a patellofemoral OA, can manage 10 minutes of walking around the supermarket. Then we've got to say, okay, you can do 10 minutes, then you need to go and sit down. You need to recover and then go again. And can you go again 3 times to get your shopping done? Mm-hmm. With our runner, we've got to say, okay, can you do 2 miles? Then it becomes an art. It's like, do you increase to 2.5 to 3? Well, probably that's the logical thing to do. But the other variable there is, well, do you do 3 by 1 mile instead of 1 by 2 miles? And give them a recovery which is possibly chondrally defensive. So you might say, and then sit on a bike and spin on the bike for a few minutes to improve the circulation within the joint, again for a descriptor. So you might progress their running distance, not by doing constant running, but by going, actually you're going to do 10 miles, but you're going to do 10 by 1 miles, because we know you can do a mile safely, and what we'll do is we'll increase your volume with recovery.
So it becomes graded exposure.
It's all about graded exposure, yeah.
No, and I think one of the answers to that question was what you said before about, I will stop you, I will do everything I can to avoid stopping you running. You've always kept them tying over with what they can tolerate, so it doesn't feel like as big a gap to bridge when it comes to return to play.
Yeah, I mean, everything's about a cost-benefit analysis with staying in sport. There are times when you've just got to totally unload the athlete when they've got a very reactive condition which is very acute, and there are times when you've got that grumbling thing, and this is the in-season scenario as well. Actually, can you have that conversation with a coach and say, you know what, they train Tuesday, Thursday, can we get away with just training Tuesday, you know, for the semi-pro, and they can still perform on Saturday adequately, they've got enough fitness? Can they do an alternate training session on the Thursday which doesn't involve them impacting on that joint? You've got the 100 kilo prop forward. Do they need to run up and down the pitch on the Thursday? Can they go on a bike? Can they go, you know, can they aqua jog? Can they do something alternate which still gives them a training goal? And then it's about the needs analysis and I guess the strength and conditioning elements as well of what we want to achieve and what alternates they are. Runners want to run. But actually, do they want to run for cardiovascular fitness? Well, then if we maintain the heart rate within a certain zone, we can maintain their cardiovascular fitness, regardless of the kit we use to do that. If we want to strengthen somebody, we can lift weights, but there are alternate ways of lifting weights and different ways we can set that up. So there is that, and then it's, you know, the obvious things. Running in a straight line is less stressful, so we decrease the pace to run in multi-direction. You know, and remembering to decrease the volume of straight line running before we do.
Is that a common mistake? Because the people have got a pace in a sagittal plane. When they introduce cutting, do they forget to cut that pace?
Yeah, I would say. And also, there's a skill to cutting which you need to build in, and sometimes it's re-engaging the skill. So you might, if we take cutting as an example, you might build that up through, well, get them to side lunge. And they get them to almost side lunge with a big step and a land, and then look at first pace. So they do almost a side lunge with a second lunge or a second step. And you gradually build into that scenario. And you look at the how they cut, and you might look at how they control it, and you might look at the cues you want to give them to think about in and around the task. And again, we spend a lot of time re-engaging, especially because we see a lot of athletes obviously are rehabilitating, building confidence in their ability to change direction and accelerate and jump and land and accept load. So we do a lot of drills involving changing direction at a cone built up through a lunge or a slow speed run with exaggerated form or very short distance change of direction. So they can't build up a lot of momentum, and there's a lot of variables which you can build into the scenario. So we spend a lot of time doing it, so I guess it's important, and the fact we spend a lot of time doing it, I guess, thinks some other people may not, because they don't have that luxury of time. But it isn't so simple as you're asymptomatic on the bed, and I'm sure I'm preaching to the converted in the listenership that you don't hurt on the bed, therefore you can go back to sport. There's a lot to that.
Yeah, I mean, if that's a common mistakes, I suppose we could exhaust. The second opinion work, we both know, is challenging but very rewarding. You become a bit of a detective. Where do you feel the common mistakes lie that end up people needing you?
I guess in the second opinion work I see, it probably splits into two, which is quite complex movement skill and issues with quite complex movement skill. But the other one is probably some fundamentals missing, like strength, like range of movement.
So you don't always try and reinvent the wheel?
Much to the disappointment of most of the people who come for second opinion, it's usually quite simple. It's usually we stick them on a nice kinetic dynamometer and there's a 15-20% difference between limbs. They don't get over some of our absolute minimum standards for strength within that leg to be able to perform. And those are probably one group, and then the other group is some movement skilling. And the way they move is still stressing the joint. And classically they do quite high-speed valgus, or they hyperextend, or they do something like that when they're moving, which again, we use our fancy toys, which are high-speed cameras and things like this to look at, so we get to see. But you do use the Mark 1 eyeball a lot. But the high-speed camera is an adjunct. And it does show a lot. But again, you can pick up a high-speed camera now for a couple of £100.
Mm-hmm.
And as long as you've got decent lighting, you can pretty much do that thing, and it's just about seeing and seeing again and again and again. I was regarded as a knee expert, but I spent 3 years with swimming dealing with shoulder problems, which everyone's amused about. But for me, it was great because I tried to use the skill set I learnt with knees in shoulders, which amuses my colleagues. And you've got one of my good colleagues, Ian Horsley, coming on in a while, and it amused him no end, but I used the same approach to knees to shoulders, and it pretty much worked okay. We did all right.
Of course.
We got 6 Olympians out of our training squad, so we did all right.
You got them over the white line, which is what you were saying. Good. And I mean, common mistakes is quite broad, but would I be able to probe you for some pet hates?
Yeah, I guess probably trying to declassify which gluteal muscle you're using. Saying this is a glutemax exercise or a glute med exercise, it's pretty much a gluteal exercise. Mm-hmm. They all do a bit of everything. That's probably one of mine. Just say you're doing the glutes. It's easy for the patient to perceptually get. And if you've got a frontal plane problem, do frontal plane exercises. And if you've got a classic knee collapse, then do a exercise which involves strengthening the knee collapse.
So don't hide from the problem too much.
Yeah, if they've got a frontal plane problem and you're doing clamp, they ain't going to get that much better. So that's do what you see. What it looks like on the tin invariably is what'll fix it. If they're not bending their knee and they're not flexing at their knee, so they're doing a very hip-driven strategy or not dorsiflexion at the ankle, that's probably what you've got to fix. So what it is on the tin usually is what it is. So that's what we call our duck scenario. If it's a duck, treat it like a duck. So it quacks, it's got bills, it lives on a pond. Don't do stuff which is involved with a duck-billed platypus. So yeah, the first two there would be, don't try and get down to fascicular level of muscles. Mm-hmm. It's a big muscle and it's got a single innervation. Second is deal with what's in front of you. First and foremost, that'll probably help you. And then I guess the third thing is there's no real magic to progression. It's just logical, steady stages. And you can't magically go from jogging at 12-minute miling to sprinting at 10 seconds for the 100 metres. There's just a progression series which happens.
And I suppose we touched on another in terms of the some of the more passive modalities, and taping being one of them, don't kid yourself on what you're achieving. You still will need to get to the crux of the issue eventually.
Yeah, all the modalities are an adjunct, and some people will be better at manual therapy, some people will like acupuncture, some people will like taping. I don't have an opinion. Do what you got to do to be able to train the individual, but perceive it as an adjunct, which allows you to train the individual, get them to exercise. Again and again and again, when we hit the NICE guidelines and the evidence-based medicine, the only thing which works is exercise. So sooner or later, we put them in a place where we can exercise them.
And make sure that they're aware of that as well.
Yeah, passive's going to make you feel better, but sooner or later, you've got to train.
Get stuck in.
And within that training, you've got to get stronger, and you've got to develop the miles.
Yeah, I mean, and to wrap up a little bit, Lee, we haven't had chance or time to talk a little bit more about some of the ACL-based protocol work. I know you've got some new work in that area out soon. Maybe another time we'll have a chance to chat through that. But if we were to say where do people need to go to find out more from you or hear more from you?
I guess if I'm directing people, I would say certainly have a look at some of the search Scott Dye's tissue homeostasis hypothesis, just to get a fundamental background. There's a great diagram to show patients in terms of this is where you're at with your loading. We need to move you to here. That's why you're breaking. One diagram fits sort of all for that. Probably the next thing is we run a series of lectures through health education seminars in terms of the anterior knee pain and the ACL. So look on sort of www.hsseminars.com. I'm in and about the country. That works there. And if you're feeling highly intellectual, it's not really, but we run a master's in sports injury rehab here where it's very, if you like, it's exercise philosophically driven. So everything is about analysing exercise and then developing exercise rehab programs. So that's probably the plug. And
we'll have a chance to pop all this on some show notes that we can send out to everyone as a newsletter, and we can maybe have some attachments to that as best we can. In terms of you as a second opinion, you have a personal website, I understand.
Probably more than the personal website. Again, it sounds like plug city here at the end of the podcast.
You've earned it. You've talked to me for an hour.
But we have now set up nominally an ACL clinic, but essentially it's a knee injury clinic for people to come in if they want second opinions doing, if they want some of the more fancy assessment tools running around their problem. And again, if they look up the knee research, knee biomechanics and injury research element of the University of Salford website, that'll direct you down to the clinic. When that's up and running, we'll happily work people up a big fancy assessment.
Okay, so thanks a lot, Lee. I know you're a busy man, and thanks for housing here at the University of Salford. And maybe another time we'll get a chance to chat more about the ACL and other bits and pieces around the knee.
Pleasure, Jack. Thank you.
Many thanks once again to Lee for his time, and I'm sure he'd love to hear your thoughts on the topics discussed. He recently joined Twitter, and you can find him at LeeHPhysio on there. I've been trying to work out how to list the next few requests without sounding needy, but I'm struggling, so I'll just reel them off. To get the most out of our podcasts, subscribe on iTunes, review and rate the show. Head to choosehealth.co.uk to subscribe to the newsletter, which is out later this week, and follow at TPM Podcasts and at choose_health on Twitter. I don't ask much, do I? Episodes should start coming thick and fast from now, as we have interviews with Dr. Ian Horsley on the contact shoulder and with Mike Stewart on pain education recorded and ready to go. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.